Hello, friends. Welcome to my YouTube channel Pathology Academy. I am Dr. Aditi Kumar, and today I will be talking about some common malignant salivary gland tumors. So, let's get started. Common malignant tumors by frequency are mucoepidermoid carcinoma. Always remember that this is the most common malignant salivary gland tumor, and it's followed by adenoid cystic carcinoma, acidic cell carcinoma, polymorphous adenocarcinoma, salivary duct carcinoma, carcinoma expiomorphic adenoma, myoepithelial carcinoma, clear cell carcinoma, epithelial myoepithelial carcinoma, and basal cell adenocarcinoma. I will be talking about the common ones. So let me start with the most common malignant salivary gland tumor, mucoepidermoid carcinoma. It affects the parotid gland more than it affects the minor salivary glands, and when it affects the minor salivary glands, it especially affects the palate. The cells are three types: mucinous, squamous, and intermediate. And it is categorized into low, intermediate, and high grade based on cystic component necrosis and mitosis. Histologically, you will see mucin filled cysts, squamoid cells, and solidness. Prognosis is good in low grade and worse in high grade. Here you can see three types of cells in the slide. The green arrow depicts the mucinous cells, the red arrow depicts the epidermoid or the squamoid cells, and yellow arrow depicts the intermediate cells. So this is a micrograph from microepidermoid carcinoma. In low-grade mucoepidermoid carcinoma, the architecture is predominantly cystic. Cells are mostly mucinous cells with few epidermoid cells. The nuclear ATPI is minimal. Mitotic rate rare or absent. Necrosis absent. Perineural invasion absent. Behavior is indolent with excellent prognosis, and MAML2 rearrangement is frequently present. Histologically, it shows cystic spaces with mucin, bland nuclei, and no significant pleomorphism. In intermediate grade mucoepidermoid carcinoma, architecture is mixed cystic and solid. Cells are more intermediate and epidermoid. Nuclear ATPI is mild to moderate. Mitotic rate is low to moderate. Necrosis is focal or absent. Behavior is variable. Prognosis histologically less cystic than low grade, more cellular, and early signs of pleomorphisms are visible. In high-grade mucoepidermoid carcinoma, the architecture is predominantly solid and numerous epidermoid and intermediate cells are seen, whereas few mucinous cells are seen. There is marked nuclear atypia, the mitotic rate is high, necrosis is present, perivascular or vascular invasion is common, and the behavior is aggressive with poor prognosis. They may sometimes resemble squamous cell carcinoma. Histologically, you will see solid sheets or nests of pleomorphic tumor cells with frequent mitosis and comedonecrosis. There are many types of grading system for mucoepidermoid carcinoma. Here I have talked about Armed Forces Institute of Pathology grading system, which is a point-based system. So the points are given on components like intracystic component, neural invasion, necrosis, mitosis, and anaplasia. And depending upon the points given to them, as I have written here, intracystic component less than 20%, there is 2 points. Neural invasion is 2 points. Necrosis present is 3 points. Mitosis more than or equal to 4 per 10 high power field is 3 points. Anaplasia is 4 points. So if the total of the score is 0 to 4 points, then it is low grade, 5 to 6 points intermediate grade, and 7 to 14 points is high grade. I follow AFIP, that's why I have mentioned here the AFIP point based grading system. Adenoid cystic carcinoma. This one is an interesting tumor. And the site is mainly minor salivary glands, palate, and submandibular gland. Key features are perineural invasion, which is the hallmark of this tumor, and it is a slow growing tumor. Always remember, it's a slow growing tumor. Histologically, you will see cribriform pattern or Swiss cheese pattern, tubular patterns, solid patterns, etc. It is positive for CKIT. Remember that it is positive for CKIT and prognosis. There are late recurrences, distant metastasis to lung, long survival, but incurable in many instances. You can appreciate the cribriform pattern or the Swiss cheese pattern here of the tumor, adenoid cystic carcinoma. Talking about ethnic cell carcinoma, it mainly affects the parotid gland. The cells have serous acinar differentiation with granular cytoplasm. Histologically, you will see microcystic, papillary cystic, follicular, and solid patterns, and the prognosis generally is good but can recur or metastasize. This is a micrograph of ethnic cell carcinoma. Here you can see the cells have granular cytoplasm and eccentric nuclei with minimal pleomorphism. Carcinoma ex pleomorphic adenoma. Well, the definition is malignant transformation within a pre existing pleomorphic adenoma. Histologically, what you will see is residual pleomorphic adenoma with malignant epithelial component, which is often either a salivary duct carcinoma or an adenocarcinoma. And the prognosis is poor if high grade, depends on extent of invasion. Here you can clearly see the demarcation between pleomorphic adenoma and adjacent carcinoma. So this is a case of carcinoma ex pleomorphic adenoma. Talking about salivary duct carcinoma, it is mainly affecting the parotid gland and histologically it resembles the ductal carcinoma of the breast. Very common features are cometonecrosis, cribriform growth, and HER2 positivity is seen in these tumors. They have aggressive behavior and poor prognosis. Here you can appreciate the salivary duct carcinoma. You can see the tumor cells within the desmoplastic stroma, which resembles the breast tumor. Polymorphous adenocarcinoma. The main site of polymorphous adenocarcinoma affected is the minor salivary glands. Histologically, diverse growth patterns are seen and perineural invasion is seen in these tumors. The key feature is cytologically they are uniform tumor cells despite their architectural variability, which could be of many types like single filing arrangement, trabecular, tubular, reticular, papillary, solid, and cribriform pattern. And prognosis, they have an indolent course. Myoepithelial carcinoma. Histologically, myoepithelial cell features can be spindle, plasmacytoid, or clear. Immunohistochemically, they are eccentric, SMA, and calpain positive. And behavior, they are locally aggressive but may metastasize. Here you can appreciate the spindle tumor cells of myoepithelial carcinoma in this micrograph. The grading and staging is based on histological grade, tumor size, nodal status, metastasis, perineural invasion, lymphovascular invasion, and mitotic rate are key prognostic markers. Now here I will be discussing about some MCQs which are commonly asked in the exams. First, what is the most common malignant salivary gland tumor overall? The options are adenoid cystic, mucoepidermoid, acidic, salivary duct, carcinoma. And you all know the mucoepidermoid carcinoma is the most common malignant salivary gland tumor overall. So the answer here is answer B or option B. The next question is which malignant salivary gland tumor is classically associated with perineural invasion? There are four options given to you: mucoepidermoid carcinoma, acidic cell carcinoma, adenoid cystic carcinoma, and basal cell adenocarcinoma. Here they are asking about classical association with perineural invasion. I have told you in my lecture that that is adenoid cystic carcinoma. So the answer is option C, adenoid cystic carcinoma, and it's classically associated with perineural invasion. Which gene fusion is associated with adenoid cystic carcinoma? The answer to it is MYB and FIB. You have to memorize this. Next question is mucoepidermoid carcinoma typically shows which of the following cell types? Option A, mucinous squamous intermediate. Option B, clear granular keratinizing. Option C, oncocytic basal spindle. Option D, myepithelial ductal serous. You all know that mucoepidermoid, the name only tells you it's mucinous, squamous, and intermediate. Next question, which malignant salivary gland tumor histologically resembles the ductal carcinoma of breast? Answer to it is salivary duct carcinoma. I have told you in the lecture. Next, which immunostrain is typically positive in adenoid cystic carcinoma? This also I have told you in the lecture. It is c-KIT. So the option B is the right option. Next question. Which malignant salivary tumor has a cribriform Swiss cheese pattern? I have emphasized on while I was detailing about adenoid cystic carcinoma that in this the pattern is characteristically Swiss cheese pattern or cribriform architecture. So the answer to this is C, adenoid cystic carcinoma. Next question. Which tumor is associated with serous acinar differentiation and zymogen granules? So here you can see in this question they are asking about serous acinar differentiation and granular cytoplasm. So the answer here will be arsenic cell carcinoma, option B. Next question. A polymorphous adenocarcinoma is most likely to arise in which location? A. Parotid gland, B. Submandibular gland, C. Palate, and D. Paranasal sinus. I have told you in the lecture. The answer for this is C. Palate. Again, this is a very important question, which is not typically a feature of adenoid cystic carcinoma. A. Rapid growth, B. Perineural invasion, C. Distant metastasis, and D. Cribriform architecture. I have told you that slow growth happens in adenoid cystic carcinoma, so option A is the correct answer. Next question. Which tumor is most likely to recur and metastasize late even after complete excision? The answer to this is adenoid cystic carcinoma. So, I have explained the most important features of common malignant salivary gland tumors in this video. I hope you have understood that well. See you in the next video. Bye for now.